Hey, good afternoon. Thank you very much for attending this extended Brownback seminar series at GHP. Today we're very delighted to have Dr. Rajani Ved to present to us on primary healthcare in India. I'm sure all of you have, lots of us actually in the audience, I know, quite familiar in India and have a lot of work in India. And so it's really looking forward to this talk. Dr. Rajani Ved is Director, Health at the India office at BMGF, Bill and Melinda Gates Foundation. She's a public health physician, technical advisor, and implementation specialist for almost 30 years, with lots of experience working in community-based health service delivery, health system strengthening, and also in scaling up. Before joining BMGF, Rajani was the Executive Director of India's National Health System Resource Center, which I think, again, many of you know of it because of all the work that they have done. And it is really the think tank, the brain to support a lot of the work that the Ministry of Health in India did. And in 2015 to 17, Rajani co-led the Ministry of Health's Primary Healthcare Task Force for India's new national health policy. So you see her long involvement in that area. And she was also a key person in implementing the ASHA program, which again, many of you are aware of. And with us, she's not a stranger because she was actually a Lown Scholar at the School of Public Health. So with that, welcome, Rajani.
Thank you, Winnie. Thank you, everyone, and it's a pleasure to be here. I'd also like to say, in 2019, I think I made a presentation on India's primary healthcare reforms. We were just starting our journey then. So while it's deja vu, we can think about what happened in the last few years, and that's what I'm going to present to you. But I think when I presented them, I had not much context relevant stuff in there. So perhaps now there is, because India in the last 15 years for 17 now, has been working on strengthening health systems, moving away from vertical programs and towards health systems. And so a little bit of context, because that's what really forms the basis for the primary healthcare reforms today. So should I just go through the presentation? People can stop and
you can decide whether you want people to interrupt in the middle or you want to go through the whole presentation.
I don't mind being interrupted because
okay, and it's more interactive. Great.
Right. So my presentation is going to focus on the primary healthcare reforms, but the context is that in 2018, the government of India announced a set of programs called Ayushman Bharat, which means Bharat is India, of course, and Ayushman means stay well, stay healthy, roughly translated. The logos at the bottom really epitomize several things, in fact. One, the shift from selective to primary health care. So as I talk to the presentation, you look at the expanded range of services that the government has to offer, but also literally a political statement about rebranding existing peripheral health facilities to make them sound new and different from what existed already. So I think that was a strong political statement that caught the attention of people. And in designing the logos, we were so focused on the inside circles so that they could mean something to people. But I think the political intent was really much more than we grasped at that time. So the difference between the technical and the way political people and policymakers think. I just wanted to provide a little bit of context to people who are not familiar with India, and I think most of you are, but still. So the triangle really is intended to convey the primary healthcare system in India, which is at the sub-district level. It's universal and free to anyone who accesses the public sector system. So right at the bottom, we have in every village and every ward in the country, one community health worker who's called the ASHA, and one Anganwadi worker who's literally a nutrition and early childhood development worker. So we have 1 million ASHAs and about 1.4 million Anganwadi workers across the country. They essentially, their functions are to look at reproductive, maternal, newborn child health, a little bit of adolescent work, public health functions, which have really been reinforced during COVID. Originally, it was very limited to looking at water stagnation, but during COVID, this team played an enormous role in outbreak surveillance, in contact tracing, potentially telling us that there's a huge role for public health functions and primary healthcare integration. They also participate in some public accountability functions through village community committees called the Village Health Sanitation Nutrition Committees in rural areas and Mahila Arogya Samitis, or women's collectives in urban areas. It's interesting that our collectives in rural areas comprise of both women and men, but in urban areas, it's restricted to women only. And part of the reason is, this is my recollection, is that they said men in urban areas would be very difficult to deal with, so let's just make committees of women. The second or the first level of facility is called the Sub-Health Center. It covers a population of 5,000 and they're only in rural areas. We do not have this level of facility in urban areas. It's largely ambulatory care, staffed by 1 or 2 auxiliary nurse midwives. Now, these are women who have an 18-month formal training in basic primary healthcare competencies, but mostly related to maternal and child health. Also, in many states of India, 1 male multi-purpose worker who was supposed to do all of the public health functions, actually conceived very early on in the 40s and 50s. But because the male workers were very difficult to deal with, and the women and men had tussles, the men didn't stick to the male workers didn't do what they were supposed to do. So slowly states allowed these cadres to die away. And now we are bringing them back in to address chronic diseases. So this center has 1 or 2 female workers and maybe one male multi-purpose worker. And so they also do reproductive, maternal, child health, delivery of immunization services. The ASHA and the Anganwadi worker are really much more about health promotion, prevention, mobilization. But the ASHA also has a drug kit to do basic community level care, including care for the newborn and the provision of antibiotics just for newborn sepsis. Now, at the subcenter level, the ANM is empowered with far more medicines. Many subcenters in the country, especially in the northern states, undertake delivery services, so about institutional delivery. So about 10 to 15% of deliveries in India still happen at this level. Not the most optimum situation, but they continue to happen. Now, they also do public health functions and undertake social audits. So there's a new committee created at this level as part of the primary healthcare reforms called the Jana Arogya Samiti, means community health collectives. And they are responsible for undertaking village meetings and holding service providers accountable. They also have funds coming to them. And then at the next level, and I'm so sorry, it's very tiny font, but it's a primary health center, 30,000 population in rural areas and 50,000 in urban areas. So in urban areas, we do have an urban primary health center. And there you have medical officers, both Western trained medical officers and 1 practitioner trained in Indian systems of medicine, either Ayurveda, Unani, homeopathy, Siddha. We have 4 streams in India. And then a pharmacist, a laboratory technician. This is normative. It's not there that it's there in all of the country. You will find it in the southern states of India. You would definitely find this composition the way I'm describing it. In the northern states where there are huge HR constraints, you may not find all of these people. Very often, you would find primary health centers that have only the Ayush practitioner and no one else. But this is the normative situation. And they also, some of them are 24/7, in which case there are institutional deliveries happening there. They may have from 0 to 6 beds. So some may have just ambulatory care, but some may have up to 6 beds and severe. The community health center is at the population of 100,000. Normatively in a district, we would have, these are called blocks, we would have about 10 in a district. So roughly this is a sub-district structure, and then it feeds into the district hospital. The community health center in the southern states also serves as a first referral unit for comprehensive emergency obstetric care. So India's evolved. All of our programs originally were catered around maternal, newborn, child health services. So the system was developed in that way. So all community health centers at the level of 100,000 population are intended to be first referral units with obstetrician, pediatrician, anesthetist, and a surgeon or an internist. Now, on the text on the right is essentially in the last 15 years, as I said, a lot of work on health system strengthening. So private sector engagement to provide maternity services and limiting methods for family planning, which is largely female sterilization. In some areas, private sector is also contracted to provide antenatal care once a day in a district hospital. In urban areas, private sector is engaged in providing specialist services in vulnerable and slum populations. We have ambulance services from 0 in 2005 to almost 25,000. And this is another huge, not just in terms of quality of care and access, another big political statement. The ability to provide ambulances and ensure at least within 30 minutes taking patients to a largely started for institutional delivery, but now it covers all conditions. So this has been one of the biggest reforms in India in increasing access and coverage. Mobile medical units for remote areas. Telemedicine, we had started even before COVID, but now telemedicine has just accelerated across the country, or at least the intent has. It served a very useful purpose in COVID, but now it's being seen as a way to compensate for the shortage of human resources. So we have telemedicine starting from the village level, where every month at every village, they have something called a Village Health and Nutrition Day, and in urban areas, an Urban Health and Nutrition Day. And even there, the auxiliary nurse midwife who's supposed to be doing antenatal care, immunization, getting women together to speak about prevention promotion, is actually holding a tablet and trying to connect patients to a doctor at a district hospital. So that kind of already in that compressed amount of time. So this is something, and as I'm speaking, I'm going to talk about areas in which further investigation is needed. This is certainly something that we have to study. This push towards telemedicine, it's a very useful tool. I'm just not underestimating its use, but its substitution for HR, its use in communities, and in a sense, disempowering every lower level of worker by saying, you can't deal with it, so now the higher level person has to deal with it. So there's not a clarity in for what conditions they really need to refer. It's like log in this many telemedicine patients a day. That's becoming a kind of a target. And that's a little bit risky. And then diagnostic services. As I'll show you later, costs of diagnostics and medicines constitute a huge proportion of out-of-pocket expenditures. And so many of the states have contracted out diagnostic services to the private sector, and they have hub and spoke models. So the spokes are where the blood samples are collected or any other samples, and the hubs are where runners take them, or if it's a private sector, they generally are motorcycle people to come and pick up the samples. And then this has been another big reform in the country, creating systems for procurement, distribution of medicines and consumables, centralized agencies, rate contracting, negotiating with manufacturers to reduce prices. This has been another huge reform. In many states, this has contributed to actually bringing down the cost of medicines, because this is what generic medicines and access and availability, another very important political statement. So this is basically just to set the context. So in 2018, when this was launched, there were two schemes that were launched. So this primary healthcare seat scheme, which was intended to expand services beyond reproductive, maternal, newborn, and then a social protection or health insurance scheme called the Pradhan Mantri Jan Arogya Yojana, addressing 40% of the poorest through both the private sector and the public sector. And the intent was that the health and wellness centers would serve the referral and the gatekeeping role between the primary and secondary tertiary centers. Interestingly, and another area to study is the institutional mechanisms for both of these programs. PMJ is governed by an entity that sits outside the Ministry of Health and Family Welfare, and the health and wellness centers are run by the Ministry of Health and Family Welfare. And there are some tensions and stresses between these two institutions, and therefore the referral and gatekeeping is almost forced, and therefore often doesn't happen. Original intent was that it would be a continuum of care. The health and wellness centers, PMJ, patients coming back, and therefore then you reduce readmissions, you pick up complications early, so that the PMJ has less burden, and this serves as a gatekeeping function, but it's not really happening. Now, so why were these PHC reforms launched? We've been using this slide ever since we've been trying to convince the government of the need to launch PHC reforms. So first we had selective RM&CH, but now we have to move because the epidemiological transition. And at that time, it only addressed 20% of healthcare needs. This low utilization, so we have 150,000 sub-centers and primary health centers in the country. All of these are providing, at that time, were providing only 11% of care in rural areas, and 3% of people actually reported seeking care at these levels. Now, fortunately, the latest data in 2021 has shown that the proportion of people accessing primary healthcare has increased enormously. Across states, it's different, of course, it varies. But the fact is that when you strengthen primary healthcare, the footfalls increase. And what is particularly important is more women are going there simply because those places are closer home, better equipped, more staff, more medicines, more diagnostics. This is all the rationale for it. The death from NCDs. India has a huge non-communicable disease burden. And 56% of our mortality is premature from NCDs. Another major problem is out-of-pocket expenditures. And I just want to share with you too, for 15 years, the focus has been on providing free institutional delivery for women, no matter where they deliver. Now, out-of-pocket, this is data from 2018. Out-of-pocket expenses for normal delivery in the public sector is 2,000 rupees, 1/3. How much is that? $30? Whatever. Yeah, roughly that. But in the private sector, it's 6 to 8-fold higher. For C-sections in the public sector, it's about $75, and in the public sector, private sector, 6 to 7-fold higher. And so when people say engage with the private sector, one has to consider also the regulatory environment in India. It's often very simplistic, and also the range of providers in India, from informal providers to highly trained physicians. There's a whole range of private sector. And how do you engage with these people when we don't have any control over the amount of money that we charge? And then out-of-pocket expenses for chronic cardiovascular disease and chronic kidney disease is 3 times higher in the private sector. And then, of course, we continue to have the challenge of persistent inequity between tribal and non-tribal areas, between women and men, and rural and urban areas. Now, these were our design challenges. How do you do service delivery reorganization from a central program when the health systems across different states are at varying systems of maturity? So for those of you who are familiar with India, we have the same model for Bihar and Uttar Pradesh as we do for Tamil Nadu and Kerala. And no surprises, if primary healthcare reform has proceeded much, much more rapidly in the southern states than it has in the northern states. How do you design the components of service packages? What do you offer at each level of facility? And I'll talk to you later about the factors that operate, like power hierarchies, the ability of the legal scope of practice for every level of worker. So how do you offer that service? For instance, medical abortion would be relatively easy to offer at a primary health center, even at a sub-health center, because a nurse could do it. But because the scope of practice doesn't include that, we allow it in primary health centers only when there's a Western trained medical doctor. So you take services out of the reach of women in most instances. How do you ensure that? So who provides the services? What kind of competency building? So competency building, 2 kinds: clinical competency building, but also population performance orientation. Hitherto, the ANMs only had to focus on immunization and antenatal care and family planning, which meant that they were addressing a smaller subgroup of the population, basically pregnant women. But now you're expanding to the whole population. And so how does the team of providers, or even the individual provider, think of their job as a population-oriented job rather than a clinical? So both, you have to have both. You can't have one or the other. Clinical competency one is relatively simpler. The population performance orientation is much, much harder to get. How do you ensure that the supply of medicines, notwithstanding efficient procurement supply, going down to the lowest level and being able to provide uninterrupted supplies of medicines for hypertension and diabetes? I think that's the big challenge, because you have different classes of medicine, and sometimes one class of medicine is available. So somebody who's been on antihypertensive for 6 months suddenly gets another antihypertensive because that particular medicine didn't come in time. IT system, digital is all the rage now, but how do you create this ecosystem that makes sure access, quality, coverage, and accountability are ensured? So despite all of this telemedicine, we're not looking at prescription audits, which should be so simple to do, because the doctors are prescribing either through writing or a WhatsApp message or something. And so one should be able to compile all that and look at the nature of prescriptions. Leverage community processes to improve participation and enhance accountability. Not so strong in some states, not in others, but now we're going to have to do it for a much larger range of conditions and to make a bigger team accountable to the public. Financing for primary health care. The overall budget has increased. We're taking loans from the World Bank, and I'll talk about that a little later, but it's still very much input-based financing. It's a set fixed budget for every facility in the country, no matter the number of footfalls they cater to. So we have to move to some form of capitation-based payments. but it's difficult to do. People are not willing to take the risk. And it's also another political issue is how do you experiment with this kind of things in a couple of districts unless you have a lot of political buy-in for that. Private sector, you have a variable regulatory environment, so engaging private sector is not without risk. And how do you structure secondary and tertiary care? So you can't do all the reforms at the primary healthcare level and leave the district hospital and the medical colleges or the tertiary institutions completely out of the picture, because you do have to have that mechanism of continuum of care, which, as I said before, is a little bit dicey right now. And finally, there's a huge amount of change management required. I mean, you will see the paradigm shift as I talk through it. How do you do this? How do you get institutions and partnerships and the knowledge base to say, this change is happening here and this is how they've overcome it, But this is perhaps the hardest thing in this primary healthcare reforms. It's going to take a decade or more to overcome the legacy issues. So anyway, so our recommendation in the primary healthcare task force was convert all of the peripheral centers to something called a health and wellness center, reorganize service delivery by increasing ambulatory care at lower levels and making sure deliveries and other conditions that might require acute care, complicated care higher up to the higher up levels where you do have doctors, where you do have other facilities. Expand the service package, but not just expand the service package, make sure it's backed up by availability of medicines and point of care diagnostics. Referral protocols and IT solutions to strengthen continuum of care, such as telemedicine. Strengthen the quality assurance standards of all health and wellness centers. So before we used to have quality assurance standards up to the primary health center level, and now we have to bring them downwards. And undertake perhaps the most important of all, population enumeration and empanelment of a population to a particular center. I mean, this is done in some countries, notably the UK. In India, it's very difficult to enforce because we have no law. Anybody can go anywhere. You can go to a tertiary institution for a headache. You can go to the local dispensary, and there's no way of making sure that it's going to meet a lot of resistance. But we do have experience in doing this for immunization and doing this for antenatal care. So women in a particular catchment area know that this is my subcenter. The challenge is to move this to the entire population. So this basically in 2015, we had the task force. In 2017, the National Health Policy, all of which reiterated this. 2018, the first Health and Wellness Center was launched with operational guidelines. And our goal for 2022, end of this year, is to convert 150,000, all 150,000. By now, we have about 110,000. We've reached whatever target is meant to be reached, we have reached that. How we've reached that and what the quality is another matter. Oh, and 2021, I hope this is not being recorded. Is it?
It will not be made public.
Okay. I have to remember I'm no longer with you. If I had been there and said these things, it wouldn't have mattered, but I'm so additional financial commitments, of course, oh my gosh.
So that's a clarifying question somebody has right now.
Okay.
Can Jan Arogya Samiti work effectively due to political leader participation in Samiti?
They're just being set up, but we do have experience of the village committee. So Jan Arogya Samiti is a conglomeration of the village health committees under it. So one Jan Arogya Samiti would possibly have 3 to 5. And there is panchayat or local representative participation, elected representative participation. Does that answer this question? Yes. That's okay.
Yeah.
Thank you.
So I also want to reiterate this. People think, and it's meant to be thought that way, that health and wellness center are these new centers that are being created. They are not. They are these existing centers that are renamed, relabeled, repainted by adding on a lot more facilities. They continue to, these are the centers, so they will not change. So you refer to them as a sub-health center, health and wellness center that provides one level of care, and a primary health center, health and wellness center that provides more complex care because you have a trained medical officer there. So this is our goal. 21-22, we've reached the 120,000 mark. By December 22, 150,000. To me, the December 22 deadline is great because then people, the states and the district nodal officers and implementers will stop worrying about targets and putting in numbers on the portal and start to actually do the work, the real work, because there is a certain criteria of functionality defined and they have to upload every day on a portal. So does it have the logos painted? Is the infrastructure in place? Do they have a new team in place? And I'll come to the team. Have they started screening for non-communicable diseases? There's one more. Oh, IT. Do they have the software and the hardware in place? So if there's a tick against all of those conditions, then they meet the criteria of being functional, and then they're marked as a target. So everybody is busy making sure that those ingredients are in place so that by December 22, we reach this goal. Then everybody will heave a sigh of relief and say, okay, now let's get on with the real work and start doing it properly, which will take a decade from now, I hope. All right, these are the key components. So the first at 12 o'clock position is expanding service delivery, which has perhaps been the most effective way of getting more footfalls into our peripheral centers, which was really the objective of this whole exercise, is that this network of facilities gets used. Then there's using telehealth for referral and continuum of care, expanding human resources, moving from an individual provider to a team of primary healthcare providers, adding medicines, diagnostics, doing much more health promotion, a focus on wellness, having a robust IT system, creating infrastructure. In 2018, when the program was designed, the Prime Minister was very concerned that this does not become an infrastructure project because infrastructure projects are prone to leakages. In 2021, given COVID and the understanding that the lack of infrastructure was what caused a lot of problems, we have now launched upon a health infrastructure mission with loans from the World Bank to actually create infrastructure for this. But it was good that in the first 3 years, the attention of the implementers was focused more on strengthening these centers rather than building new buildings, because building new buildings should have taken all their time. And then so in a way it was, I mean, it just happened that way that COVID came, but the focus of the first 3 years was not really on buildings, and now it will be. And let's see how that evolves. Creating partnerships for knowledge and implementation. So when I was at the National Health Systems Resource Center, we set up something called Innovation and Learning Labs, basically to study change management at the level of a block, the 100,000 population, which would have roughly 3 primary health center, health and wellness centers, and about 20 of the sub-centers, the lower ones. And so that's a smaller unit that one could study. And so we engaged with medical schools, with other NGOs to say, all you need to do is to post a team here of 3 people who will monitor, support, supervise, and understand how these teams are engaging and making change. And it's been really very interesting. I understand NHSRC has actually scaled the 5 original ones up to 15 in the country. And those are places to watch really. And one should be focusing much more on them to see what they're learning. And then of course, financing and provider payment reforms. And I'll talk about that. So service packages. So packages 1 to 6, we were already doing in some way or the other. The maternal newborn child health, India's progress on those for the whole country, never mind district and sub-district disparities, has on the whole been pretty good. Infectious diseases, tuberculosis, malaria, dengue, chikungunya, and the neglected tropical diseases. We have worked on, long way to go for TB, but still it's progressing. And the acute simple illnesses and minor ailments, they had very limited amounts of medicines to give, but still something, they provided something, but largely for women and children, because the target of packages 1 to 4 is women and children. But now the package 7, which was like the big new addition, was screening, prevention, control, and management of 5 common NCDs, hypertension, diabetes, and 3 cancers, and tuberculosis and leprosy, because leprosy is one of the elimination diseases for us. So that was a new package that was added. And then of course, so you'll notice 8 and 9, oral health is part of the oral cancer screening. So basically, one oral examination will tell you even about dental hygiene, ophthalmic and ENT problems, deafness screening perhaps, and for cataract. The remaining 3 will be rolled out really slowly. States in the south, which have, by the way, demographic changes where there's more aging, have already added on elderly care services. Mental health, still a far cry, but what gives us hope is we now have a Mental Health Act, which makes it justiciable, and government has to take action. So telemedicine has actually come in useful here because we don't have enough psychiatrists at district hospitals. So having telemedicine consultations with psychiatrists in tertiary centers and then setting up para workers is going to make this a possibility. Mental health is a serious problem in India. Surveys have shown that 1 in 10 Indians reports depression in large-scale surveys, and therefore This is actually, we put it at number 12 because we thought it'll be a long way for states to go, but the need is quite urgent for this one, although it's not as well set up in many states as it should be. The problem is some states have a double burden. They continue to have high maternal mortality and infant mortality, but also a high burden of chronic diseases. So this is expanding human resources. So at the lowest level of facility, where we had only 1 or 2 nurse midwives and a male worker, we now have someone called a community health officer who could be a nurse or a practitioner of Ayurveda. That's the only system of Indian medicine that could be designated a community health officer. So the shift here really is moving from this 1 to 2 person team to a team of 8 people. So the community health officer, the 2 auxiliary nurse midwives, and getting the community health workers who are hitherto seen as like part of the community, not part of the system. They're not paid regularly by the system. They only get incentives. But moving them into this team also gives us an opportunity to say we can now integrate the community health workers into the primary health care system. There's no additional staff for the primary health centers because now the understanding is with these increased numbers at the lower level of facility, they'll be able to manage more conditions and use telehealth as a way of communicating with their medical officer. So this is the unit, a primary health center and about 3 to 5 sub-centers under them. This is how service delivery will be reorganized. So frontline workers do home-based and outreach-based care. At the sub-center level, this community health officer leads the work, and at the medical officer so this is the community level, the health and wellness center level, and then specialist and higher level referrals. The treatment plan could be initiated either at the primary health. So scope of practice is very limited at the lowest level of care. Anybody who goes, so even if it's a trained nurse, they cannot prescribe. And that's a big limitation because then people may or may not go to the primary health center, particularly in cases of hypertension and diabetes, because you need confirmatory diagnosis. But again, telemedicine is our mantra there. So again, this is the same thing to say how continuum of care is enabled. Okay, somebody's asking a question.
Sure, go ahead if you want to.
No.
Yeah, what that is.
Well, we actually have 3. Do we just wait till that?
You can answer the one that just came.
Okay, so is it possible to work NCDs with very low human resources at a health and wellness center?
It's possible to screen them. So as I said, medicines, vastly expanded list of medicines. So the drug and vaccine delivery management system is an IT system that tracks the inventory. It's basically an inventory system. Increase in point of care diagnostics. And I think these are 2 very useful things. Where they work, they're responsible for the fact that our footfalls have increased tremendously. In all states, this is again a political statement, having more people come in, making sure you're making these medicines available, so very highly politicized. And there's always a market here, market is the correct sense of the word, is basically to create actually many more point of care diagnostics. And there's a real need for that kind of thing, for blood cultures, urine cultures, urinary tract infections. All of this remains undiagnosed because the district is perhaps the only place where you could do this. This I want to share with you all. I talked about population performance orientation. This was one of our community health officers and one of the innovation and learning sites that we had. They've just made up this chart on the wall. Essentially, this is what they should have. Disaggregating the population by age, the services that they're expected to provide, what is the disease burden in the area. And so this for us is a great example of a local innovation just done by the community health officer. There's another very nice example where the community health officer does what she calls a team huddle. I mean, clearly the NGO that was supporting them was helping them. But every morning, the whole team gets together, decides what their scope of work task is for the day and comes back at the end of the day. So good examples of team-based practice, but many more examples of dissonance and not being able to work together. So this is the IT solution. I'm not going to bore you with this. It's all things to all people, which is clearly something that's not going to happen, but they're trying. I mean, to be fair, it's a very complex thing. And I don't know how many countries have even achieved this, but They're trying to make it work for frontline workers. They're trying to make it a job aid. They're trying to make sure that it can be tracked. Payment based on this, so it's a huge, and standard treatment guidelines, clinical decision support systems. It's being tried on various fronts, and someday it'll all get integrated. Financing. I just want to spend a couple of minutes on this. So there are two kinds. The ASHAs in India have always been given performance-based incentives. They never got a full-time wage. They were always given full. And I think policymakers felt that this mode of payment for contractual workers is fine. So the community health officer is largely a contractual worker. 60% of their payment is fixed and 40% is based on performance. So it's called a performance-linked payment. And her performance or his performance is judged by a range of indicators. Now, there's also a team-based finance. So the whole team gets a fixed amount of incentives on the achievement of those very same indicators. Right now, these indicators are all self-reported, and that's why a digital system is really important for us to make sure that real-time data is obtained and how they going to do it. Right now, it's very variable. The workers, the community health officer certifies and everybody above agrees and she just gets her pay, because if they didn't pay her that or him that, attrition becomes very high. So, you invested so much in getting them and retaining them and training them, can't afford to have them because you promise them X amount of money and then if you only give them 60% of that, they're all bound. A facility budget, there has been an increase in funding to each facility. There's also there's a pool of money called untied funds, which is the discretion of the team to use. There's been an increase in that as well. Provision of incentives after the facilities get certified for quality, additional amounts of money. And this capitation-based payments is something that needs to be explored. It hasn't yet begun, but we're hoping that now, once the target is met, it's something that we can start working on. Community processes, quite strong actually in the last 15 years, just have to be strengthened more and focused on chronic disease management. So we have patient support groups in many states for hypertension, for diabetes that have shown to improve treatment adherence. Not control, but treatment adherence. Just a little bit on the two new sets of investments that were made recently, both of which are, so it's almost what, some $2 billion or some huge $1 billion for the infrastructure mission and pandemic preparedness, and another $1 or $2 billion from the Finance Commission to strengthen local governments to build capacity. So that's a very interesting phenomenon. The Finance Commission in India sits every 5 years and decides how state central allocation should be. And this particular one, because it came out after COVID, decided that the way to strengthen primary health care was to support local governments. And so there's a huge amount of money allocated for that. And particularly for number 5, support for almost 30 to 40% of the funds are for diagnostic infrastructure. But the interesting thing is the trust of the governments on local bodies is somewhat limited. And I can talk later about how all the money is reverting back to the state, again centralized, because they don't trust the capacity of local bodies to actually spend it. Okay, so what are the factors that affect rollout and scaling up? So again, in a context of federalism and decentralization, how do you do centrally sponsored schemes? Because the Health and Wellness Center is a centrally sponsored scheme that is linked with conditionalities. So states that achieve certain indicators are incentivized and states that don't are penalized. And therefore that is a problem because it's often the poorer states that don't get the funding. Trust in the public health system. Our peripheral facilities are still seen as providing immunization and childbirth. The fact that they actually will have medicines for all of these conditions is still a work in progress. Urban primary health care is not well structured and we still are struggling on ways to organize service delivery in urban areas, including public health services. And then path dependency, there's a legacy of the way they do things, and then the emphasis from the political groups to say what is new. I mean, every time we go to cabinet, the question is, what are you doing new? I mean, this is the same center. What have you done other than the painting? So then service delivery organization, but the focus on NCD has had one problematic effect. And I see this in Uttar Pradesh and Bihar because I work there in both, is that there's a dilution of the RMNCH services. So our teams are not yet ready to do both because they're not equipped. And the emphasis is so much on the what is new that you have to report every day on the number of people you screen. And therefore the attention is all on that. And so the RMNCH services are actually either stagnant or dropping, and that's the worry. Our system is not used to dealing with men or women beyond the reproductive age group. And so that's another challenge. How do you get them to come to the center? Just wait. Thank you. Yeah, because that's a controversial question. Okay. Teams. Very difficult to work in teams. Very difficult for a medical officer at the primary health center level to say, okay, you are my team. Because we are trained in a very individual kind of way, and team-based care is difficult for us yet. There are lots of power hierarchies between medicine systems, Western trained physicians versus the practitioners from the Indian systems of medicine. But there is a huge emphasis on the policy side to focus on the Indian systems of medicine. There's all this drift towards culture, our cultural legacy, our Indian systems of medicine, and therefore there's an emphasis on that, but there's resistance from the Western trained physicians. We have mixed health systems, as I said before, formal, informal, a range of informal providers. Scope of practice very limited. So if only a medical officer can prescribe, and we have quite a number of primary healthcare centers in the country that do not have a Western trained medicine doctor. If they can't prescribe, then it's very difficult for people, no matter even if they've been screened for hypertension and diabetes, to get care. Multi-skilling and task shifting, a lot of resistance to that. People will not allow the community health worker to take a digital BP apparatus into the community, saying that, it connotes that she is a doctor. How we come to that, I don't know, but that's what it is. So then these are I'm not going to say very much here. So to increasing use of technology. So there's multiple apps, which makes life very difficult for everybody, including several development partners who each comes in with their own idea, and the private sector technology agencies. Everybody has a different idea, and to get those linked. And because again, we are a federal structure, some people work at the state level and then come up to the national level and say our system is working. And then that's planned for universal rollout, which really doesn't happen. Continuum of care is another big challenge. And therefore, you still continue to see flooding of the tertiary and secondary care facilities, which actually compromises care. A unique health ID is what they're talking about, but that's again a challenge. Oh, one big thing, we don't have a performance monitoring framework yet. And I think there's a lot of work to be done there. And now I know that with the World Bank loan, we are thinking in terms of a performance monitoring framework and indicators. Okay, so what has happened? There's a rising political salience. The fact that the numbers are reviewed in the Prime Minister's office in every week shows you for the right or the wrong reasons, but definitely people are focusing on health. And this was even before COVID. In 2019, when the schemes were launched, they were very keen to say how many centers, how many people screened, how many women being screened, that kind of thing. It has improved the credibility of primary health center. The latest DHS data in India shows that there's a huge increase in access to care in the primary health centers. Using NCD screening, the new part of it, has been very helpful. Well, this is anecdotal, but in many, many health and wellness centers, people have reported that they moved from the private sector to the government sector to obtain medicines, which is a welcome change. So there's high level advocacy. There is an increase in budgets, quality standards. The government has just introduced a public health management cadre, which in India has been there only in a couple of states, but there's also talk around Indian health services. For those of you who are familiar with India, we have an administrative service that actually governs the health system, but now there is talk of getting doctors and public health professionals into a dedicated Indian health service. Public health action. COVID again taught us that our primary health care completely did not have public health in it. So therefore, integrating essential public health functions into primary health care and these additional investments. Thank you.
Thank you. So why don't we take a few questions from this audience first, and then we will also invite some questions. I was just suggesting that even those who attend online, we will just invite them to speak up and, yes, please, to ask the question rather than typing in, because it's more human. So anyone from this audience? Bill?
I have been admiring from afar the success of India addressing the maternal and child health. I mean, you did many reforms previously. And from afar, I don't mind to tell you, we consider most of them, you made the progress, but no breakthrough. But on maternal child health internationally, from one person, we think, at least I thought you made the breakthrough on really implement the maternal child health program successfully and show the outcomes really improved. What lessons do you learn from that, implementing maternal child health program and incorporate it into your primary care?
Should I wait for a couple more or respond to that first?
You can respond.
Okay. I think I used to have a slide that says leveraging the lessons of the last 15 years in MCH reduction, in MCH improvements for primary healthcare reforms. I think, so 2 or 3 things that supported this: cash entitlements and free services for maternal care really improved the access of women to facilities. Ambulances, mobile medical units, increasing the number of pediatric and neonatal intensive care units in facilities. There have been 5 years, and being able to actually track, and that's why I said population enumeration and registration, we've been able to do it for mothers and children, and therefore maybe we can do it for the whole population. The fact that we have ambulances, creating entitlements for maternal and child health has meant that somehow there is an understanding about, so we have free dialysis schemes in secondary hospitals, for instance. And so that also increases it. Trauma care, the ambulances and mobile medical units have contributed to a huge amount of work on accident and trauma care, and that's also a learning. So, and the community health worker program, of course, having 1 million ASHAs,
Right.
and the hope that they will also now transition to chronic disease. There's been some of this. So.
Thank you.
Anushka, do you have a question? Oh, you had your hand up.
Sorry.
Who else? Michael, do you have a question?
Sure, that was a wonderful presentation. And again, we're so fortunate to have someone who not only has been in the midst of all of these different reforms, but has been able to be thoughtful and even have a certain amount of distance, objectivity, and critical thinking about them. So similar to Bill, my question is, what do you think will make a big difference in the next step? And as I listened to what you said, it seemed to me there are 3 different areas that haven't been very well assessed. And the first is telehealth. You know, is it just a gimmick, or is it actually de-skilling some of the primary care workers? And when do you think it'll work well? The second is incentives for all of these different, performance-based standards. Again, are they going to, is someone evaluating them? Are they going to work? What do you think? And the third was the new governance, especially at the local level, of trying to get some local accountability. Those sort of strike me as 3 areas, and I'm wondering, one, what you think about those 3 areas, and if there are any areas that I've missed. I sort of knew, the new stuff.
Telehealth incentives.
Telehealth,
Incentives.
incentives, and governance, especially at the community level. The panchayat and the committees.
So as one for India, it's different across different states. So there's no one answer. But certainly telehealth needs evaluating. Right now, regardless of internet connectivity, everybody has been given a target. What this means in terms of access to care, quality of care, the persons who are at the higher level, the sort of the doctors who are actually talking to the people are prescribing a set of medicines that are not in the essential drug list. And therefore, people are going out to buy those medicines. And nobody's tracking that. This is just observations. And there is a lot of work to be done. And in my present role, because Foundation is also supporting the rollout of telemedicine in both Bihar and Uttar Pradesh, we are trying to get a learning group together to say we have to do a concurrent evaluation of this, So that is one thing. I don't know that the government is so interested in actually having someone do this, but it's got to be done. There are various groups doing it, but in small areas, we have to do it at scale to point out and not to point out its flaws, but basically to say how can you strengthen it. Incentives. It's nicely written in policy, but we have no way of measuring. Because we don't have a performance measurement framework and not a digital system, it's difficult to validate. It's right now self-reported. The fear of attrition is very high, and therefore nodal officers are quite reluctant to add on anything and are quite happy with the self-reporting, so it keeps the workers in place. And as long as that is an incentive, then these incentives will not get paid properly. So that's going to be a challenge. And there is a performance monitoring system in place with these 15 indicators, but that's not really a performance system. It's just a list of 15 indicators, institutional delivery, tuberculosis, immunization. But that's the learning from RCH. Governance. Michael, it's mixed. In the southern states where traditionally local governance has been strong, they welcome this additional monies. And it's huge amount of money. It's a really, I have the figures and numbers, 70,000 crores. I don't even know how to translate that into dollars, but is that more than $1 billion, roughly? So that, and the reluctance of the bureaucracy to transfer this amount of money into the hands of local bodies in other states is sometimes, I think, well placed. I mean, they're right about it because there's no, but on the other hand, there's no capacity building of the local bodies. And so that's because the Ministry of Health, again, this calls for really supranational action, supra-ministerial action, just like multi-sectoral convergence. Somebody has to take a decision that the Ministry of Health shall transfer the funds. Right now, what's happening, the money is going because the Finance Commission says the money should go to the local body. It goes to the local bodies and they're reverting the money back to the central government, to the state government. That's hardly decentralization. But in the short term, if we are to save that money and not have leakages, then that's the way to go forward. The guidelines say very clearly, until such time as capacity is built, which who knows when. So that, and in terms of lessons, I think a very important part is the human resources for health, the workforce management. This whole thing about clinical competency, professional mentoring, personal mentoring, because the CHOs are on their own out there. These are trained nurses. Many of them are trained nurses. Many of them are women. And they're just on their own. And these are the other members of the team have been there for a much longer time. So how did those dynamics plus the clinical competencies to raise their credibility in the system? I think that's a very important area that needs to be.
Great. If there are no other questions here, you have other opportunities later. Let's turn to 3 questions online. And why don't we take all of them and then you can just respond. So I'm going to invite them to just speak up. So the first one from the audience is Niharika. And then we have Rahul Reddy, whom I think we all know.
Yes.
And then we have Lashmi A.R. So how about we start with Niharika, and then we'll go to Rahul and go on, and then Rajani will respond to them together. Yes, you have, I have to unmute that.
I think they have to unmute themselves. Niharika, can you unmute and try to talk?
One of you, Rahul, can you unmute and just state your question? Go ahead, Rahul, and while we will wait for the other 2 to do that.
Yeah, thank you very much, Winnie. Thank you very much, Dr. Ved, for presenting such a complex reform that has ever been undertaken for 1 billion people so succinctly. I just wanted you to reflect upon at least one example where the implementation the learning from the implementation in the initial days of the PHC reform has informed the design better, because in India we know that we parallelly design and implement as we go due to lack of time and resources. So is there something that you found in the field or a learning from the field that made you to go back to the drawing board and redesign in the initial days?
Okay, great, thanks. The next person who might be available to unmute and ask your question. So either Dr. Lashmi or Niharika. Yes, go ahead, Dr. Lashmi.
Hello, ma'am. Am I audible?
Can hear you.
Okay. First of all, thank you, ma'am, for such an informative presentation. And my question is, ma'am, how does this approach take care of the difference between the southern and the northern states?
Can you repeat again? Just it was a bit broken.
Okay, ma'am. Ma'am, I was asking, how does this approach take care of the difference between the southern and the northern states?
Differences between south and northern states. So finally, Niharika, are you able to unmute? Why don't you respond to those two questions first?
Okay, so hi Rahul. Learning from implementation, has it informed design better? I think that the Kerala example of strengthening primary health centers has actually worked better in many states that have chosen to focus on primary health centers because they have more staff there. And states like Bihar and Uttar Pradesh actually are saying, we'd rather strengthen our primary health centers first and then focus our attention on sub-centers, and so I think that was an important learning, because at least they're focusing on one level of facility and making sure that facility has all the components in place. So I think that was one learning. I think the challenge here is the states, because we don't have time, everybody is racing towards a target, the ability to pick up local innovations and actually implement them back in the program is not happening. I'm hoping that after December 22, when people have more space and there are more state health systems resource centers involved in this, maybe we will be able to pick up local innovations to inform, to change, not change, but at least adapt some of the approaches. Does the approach take care of the difference between the southern and the northern states? Actually, there were many things that we could have done to take care of the difference. The singular one being adding more staff in the northern states, because they have to deal not just with the MCH burden, but also the NCD burden. And that we haven't done. We've given the same amount of staff, expecting them to do both tasks, and it's not going to happen. And so that's why I said there's dilution. So this was one of the points I picked up in the challenges, is that we have federalism and in mixed systems at mixed levels of maturity, and therefore how do you address it? That's a challenge which we haven't taken into consideration.
Great, thank you very much. Niharika, it looks like you're not able to unmute, and so Michael, last question.
Yes, in order to do all this evaluation of all of these different efforts, I think India needs more analytic capacity. And where do you see that being developed, and how? In the public health field?
A few states have it, but it's hugely under-resourced. I think the government has to step up investments. I know that the Indian Council of Medical Research is creating a new institute for implementation science and implementation research. Of course, one institute of that kind is certainly not enough. But I think more than not having, I think it's time to actually do a landscape and say, this is what we have, this is who we have, and this is what there are a lot of efforts. Access Health is doing something on health policy systems research, creating researchers. So is the health systems transformation. But how this all comes together to support the states to actually do this, I'm not clear about. So.
Great. I think we have reached time, and so please join me in thanking Rajani for a wonderful talk, and also in person, we have an opportunity to continue this conversation. So for those who are joined online, thank you very much.